All right, all right. Thank you all so much for joining us today. My name is Kelly Toops, and I'm the Director of Nutrition at Oldways. So for those of you who are new to Oldways, we're a nutrition nonprofit dedicated to inspiring people to embrace the healthy and sustainable joys of the old ways of eating. So we're really excited to bring you this webinar today. And we would especially like to thank the National Peanut Board for sponsoring this session and for putting it all together. So just a few housekeeping notes before we get started. We will be recording this presentation and we will be posting the video recording as well as the slides from the presentation onto our website. So we'll send out an email early next week to send you the link to the slides and recording. And for the dietitians in the audience, we'll also send you an email early next week with the CPU certificate. And then one last thing before I hand it over, we're going to have a question and answer session at the end of the presentation. So if you have any questions throughout the presentation, please type them into the chat box, and then we'll try and get through as many as we can. So with that, I will turn it over.
Awesome. Hello, everyone. My name is Jada Linton, and I'm a registered dietitian with the National Peanut Board. Welcome to our webinar, Maternal and Early Feeding, Child Feeding, the Impact of Nutrition on Food Allergy Development Pre-Birth through 2 years. Now, at the National Peanut Board, if you don't know, we strive to help America's 7,000 peanut farming families improve their production practices and continue to put the world's highest quality peanut products in the hands of people around the globe. And through the National Peanut Board, America's peanut farmers have contributed more than $32 million for food allergy research, education, and outreach since 2001. One of the groundbreaking updates of the scientific report of the 2020 Dietary Guidelines Advisory Committee was the guidance on pregnancy, infant, and toddler nutrition. In this session, we will explore the key takeaways of this report as they related to pregnancy and early childhood nutrition. I'm very excited to announce our speaker for today, my friend and colleague, Sherry Coleman Collins. She is a registered dietitian nutritionist licensed in Georgia and based in Metro Atlanta. Her areas of practice include nutrition communications, food allergies, digestive wellness, and culinary nutrition. As a communicator, Sherry is a sought-after speaker, and she has presented at professional and consumer conferences across the country. Sherry has published dozens of articles in a variety of print and online publications and serves as an expert to the media. With a particular interest and expertise in food allergies and digestive health, her professional accomplishments include developing the Academy of Nutrition and Dietetics Certificate of Training in Food Allergies and authoring the Academy of Nutrition and Dietetics practice paper, The Role of the RDN in Food Allergy Diagnosis and Management. Sherry serves as a consultant for the National Peanut Board. Without further ado, Sherry Coleman Collins.
Thank you, Jada. Thanks so much for that. And thanks everyone for joining us. I am just thrilled that so many people are as interested in this topic as I am, first of all. And I'm thrilled to share with you a lot of new information because things have really changed a lot in the landscape of early feeding. So let's move right into the presentation. I think, one of the things that's the most exciting when it comes to early feeding, well, let's see here. Let me click on it and get us going. There we go. When it comes to early feeding is the many changes that have happened when we think about infant feeding and food allergy prevention. So this subject, I think, is really robust, and there's so many things that I wish we had time to dig really deeply into, but we don't, not in this slide. So at the end, I'm going to share with you some places you can find some additional information, and as we go along, I'm going to talk about a lot of research. I didn't include a bibliography in the slides, but if you are interested in the specific research that I mentioned, just let me know and I'm happy to send those to you. My contact will be at the end. So these are our objectives. You know, we're really going to talk a lot about maternal and infant diet. We're going to talk about best practices for early infant feeding, and we're going to talk a lot about peanut because that's where a lot of the research is. We're also going to talk about the dietary guidelines, which I'm thrilled to see when they come out, hopefully sometime this month. So we're going to start with a poll question, and Kelly's going to pop up a poll for you guys to vote on. What percentage of children do you think goes on to develop a food allergy? This is the question that we ask professionals a lot. We ask this question of consumers a lot, and you would be amazed at the variety of answers we get. So tell me what you think about children specifically. Is it 10 to 15%, 6 to 8%, 20 to 25%, or is it 30%? I'll give you just a minute to vote. Submit your answers. All right, Kelly, let's see what they think. All right, so 10 to 15% was the overwhelming number that you guys think, and then 6 to 8% shortly after that, and 20 to 25%, and even some people said 30%. So this is very interesting and somewhat reflective of what we see when we ask consumers. I would say when you ask consumers, you probably get more skewed on that higher end. So more people will say 20 to 25%. Good, great. All right, so this is what we know about food allergy. So this is my food allergy fast facts. And every time I said this during my practice, I said fast food allergy facts, but it's food allergy fast facts. The prevalence for food allergies is somewhere between 6 and 8% in children, which is significantly lower than most people think. Most people think it's somewhere in that 20 to 25%. But what we know is that when it comes to IgE mediated allergies, it's somewhere between 6 and 8%. Now, there are a lot of other conditions that are adverse reactions, right? That could be misconstrued or that people might believe are food allergies, but in reality, they're not food allergies. They're other types of adverse reactions. And this is what we're going to focus on today, is really this IgE mediated allergy. Interestingly, you see that number in adults is very high. That was a recent study that was done. Now, all of these numbers are self-reported. And I think that's also something that's important as health professionals for us to remember, is that, you know, all of the numbers we have on prevalence is self-reported. Some research shows that, you know, when it comes to self-reported data, 50 to 90% of the time people are wrong about their own food allergy. And perhaps that's not this 6 to 8%, perhaps that's not this 10%, but it could be some of those people as well. And it's really important that we get accurate diagnosis for food allergies, because it can be really costly, and not just in terms of money, but it certainly is costly financially. It's also really costly in terms of healthcare use and in psychosocial impact. So people with food allergies, and especially children and their families, tend to have very high levels of anxiety. So we want to do everything we can to reduce the risk of food allergies, to reduce the numbers of people who go on to develop food allergies, so we can avoid some of these negative impacts. And prevention works, but there is a critical window of time during which intervention has to happen. Otherwise, we miss that opportunity. So before we dive into the prevention, let's talk about what a food allergy is, because I always like to make sure that we're all on the same page. And again, I'm talking about IgE mediated reactions. These are reactions that happen very quickly after a food is eaten. It's usually within minutes, but it can take up to 2 hours, even in an IgE mediated reaction. If it happens longer than that, if there's an adverse reaction that happens longer than that, it's usually not a food allergy. It's also reproducible every time the food is eaten. So if somebody has a reaction to a food and then they eat it again and they don't have a reaction, it's not going to be an IgE mediated allergic reaction. It could be something else. It's not necessarily that they're not having a reaction, but it's not necessarily going to be a true IgE mediated allergy. And then sensitization does not always equal true allergy. And this slide talks about diagnosis. And I think, again, thinking about how important diagnosis is, sensitization, or having a positive skin prick test or an IgE test, tells us that an individual may be reactive in some way. They may be having, they may make IgE, but if they can eat the food and not have a reaction, even in the presence of IgE, that means that they don't have a clinical allergy. If you don't don't have any symptoms, even if you have a positive test, that means you have a false positive test. You may have IgE, but if you're not having a reaction, you don't have a clinical allergy. And we don't really know why that happens. You know, some people develop IgE and they don't have reactions. Other people have IgE and they have very severe reactions. So the way we know that is by actually having a reaction when you eat the food. So as dietitians or health professionals, you know, one of the most important things we can do is walk people through gathering a history, determining what they ate, how much of it they ate, when they ate it, and then when the reaction happened is the first part of diagnosis, and really, I think, the most important part. Outside of that, the lab testing can tell us something, but they don't diagnose food allergies on their own. And an oral food challenge is the gold standard. Sometimes they can be really hard to get because doctors don't always want to do them in their office. They can take a long time. There's obviously some inherent risk that people are going to have severe reactions. So sometimes oral food challenges can be hard to get, but they are the gold standard for diagnosing a food allergy. And this is what a food allergy can look like. It's, you know, lots of different potential signs and symptoms. Most of the time, those have to do with GI. So a lot of times it's swelling or itching in the mouth and throat, could be vomiting and diarrhea, could be bloating or difficulty with digestion in general. And this is why sometimes we see that confusion between allergy and other types of adverse food reactions. Food allergies, though, can also be much more severe. They can include things like hives. Not all food allergy reactions are going to include hives, but hives is pretty common. But the most severe kinds of reactions are called anaphylaxis, and that's where you can have difficulty breathing, where someone may have a drop in blood pressure, and these can actually be life-threatening. Epinephrine is the treatment for anaphylaxis. It's actually the only treatment for anaphylaxis, and there are no contraindications for giving epinephrine. So for people who think they may be having a severe reaction, or if you think somebody's having a severe reaction, epinephrine is the only way to treat that. All right, and these are the big 8. So there are about 8 foods that cause about 90% of food allergy reactions, and you can see those foods here. They're very common in the US diet. They're ubiquitous foods for us. They're everywhere. I would add to this sesame. We know now that sesame is probably the 9th most common food allergen in the US. It is not covered under the food allergy labeling laws just yet, but there's some movement in the Congress to get that added. So you can see all of these foods, and many of these foods are foods that they're incredibly nutritious. Actually, they're all incredibly nutritious foods that we want to feed children and we want to feed other people, but we want to make sure that they're done, that's done in a safe way. So I mentioned some other kinds of reactions that can happen, and you see some of those here. You may have questions about these. We're not going to cover them today because we just don't have time. Things like eosinophilic esophagitis and FPIES, oral allergy syndrome, which is associated with itching in the mouth and is not associated with severe reactions, lactose intolerance or other types of intolerances, and celiac disease. Definitely, these can have some similar symptoms to food allergies, but they're not considered food allergies on their own. So we have another poll question, and I'll ask Kelly to launch that poll. And I want to get your feedback again as we think about when is the right time to start feeding. As we think about the impact of mom's diet on food allergies. So true or false? This is a pretty black and white. You know, do you think that the mom's diet, or what mom eats during pregnancy and breastfeeding, is the determining factor for whether or not baby has food allergies? True or false? That's our next section. So give everybody just a minute to vote. And then Kelly, if you'll show us the results, what do people think? So about 20%, 21% of you think that's true, and 79% think that's false. So I'm really excited to share with you some of the research, and I won't spoil it just yet, but I will tell you what we know so far about maternal diet and food allergies specifically. So when we think about maternal diet, one of the areas where I think there's the most exciting research and also the most to learn is in diet diversity. You know, as dietitians or health professionals, when we think about diet diversity, you know, I always think about food that's colorful, right? Lots of fruits and vegetables and lots of foods from all of the different food groups and not eliminating any specific food. But there is no standardized definition, or there hasn't really been to this date, a a definition, agreed upon definition about what diet diversity is in the research community. And because of that, we really have a limited view of diet diversity and its impact on pregnancy. So the European Academy of Allergy and Clinical Immunology, the EACI is what it's oftentimes referred to, has a position paper that's been recently published that's calling for standardization and really making recommendations for future research in this specific area, because we think that there's probably some benefit. And I'm going to share with you some data that we have about this. But the reality is we don't have enough information yet to be able to say for sure that a diverse diet can prevent food allergies. What we do know is that a diverse diet, and really in particular a Mediterranean diet, seems to be protective against some types of atopy, which is a term that's used to describe all kinds of allergic disease. So when we think about what we know, the research is really stronger and growing specifically around preventing wheeze and rhinitis and asthma, as well as eczema when it comes to the Mediterranean way of eating. It's likely, or it seems that the benefit may be something to do with the types of fat that are in the Mediterranean diet, and that's pretty exciting. I think that the Mediterranean diet is a very delicious way to eat, and I think you might agree with that. There are lots of benefits from this way of eating. It doesn't seem to be at this point a cause and effect, but there's definitely an association. So this Mediterranean way of eating has some protective benefits. Omega-3 supplementation, as I mentioned about the fats, perhaps that's part of what's going on here. And omega-3 supplementation has shown some benefit for wheeze and asthma, but not for food allergy. And vitamin D supplementation is the same. But none of these, to this point, are pointing to preventing food allergies. So there may be some benefit from these supplements and from this way of eating, but at this point, these don't seem to show that they can prevent food allergies. What about breastfeeding? So we're talking about diet. We think about maternal diet. What about maternal diet during breastfeeding? What mom is eating during breastfeeding? Or breastfeeding in general? Does breastfeeding prevent food allergies? Well, what we know at this point is that we don't know. I hate to tell you that, but the reality is that the research is inconclusive about whether or not breastfeeding alone can prevent food allergies. It does not appear to prevent food allergies, but it also does not appear to promote food allergies. So when we think about breastfeeding on its own, some research, you can see this study here in 2008, and I'm gonna look these a little bit out of order, but in 2018, this study actually used a double-blind placebo-controlled food challenge on these children to see who developed food allergies and who didn't. And what they found was that there was no significant difference between the two groups in whether they developed food allergies from whether they were breastfed or not breastfed. But when the children were breastfed longer, there was a reduction in the rates of food allergies. On the other hand, another study was published last year that was a really huge cohort study, 26,000 children, and found that there was actually no difference in food allergies, but those who breastfed longer actually were at an increased risk for food allergy. Now, these kids all had eczema, so that could be a factor, and we'll talk a little bit more about eczema shortly. But I think what this shows us is that we just don't know yet, and there could be some big differences in geography, in other contributing factors. Think about vitamin D status, that kind of thing, thinking about the previous slide. What about foods that mom eats? So you can see those first couple, what we see is that it doesn't seem to have a significant impact. But in smaller studies right now, what we've seen with peanut is that it could actually reduce the rates of peanut allergies if mom eats peanut, and then if she feeds the baby peanut early in accordance with the guidelines. There's no difference with cow's milk allergy or with other foods so far. Again, the research, I would say, in this area, though, is limited. So we have limited studies. The other challenge with breastfeeding is that you can't, it's not ethical to separate babies into two groups and tell moms not to breastfeed. So it can be difficult to control for all the potential contributing factors. So I think there are lots and lots of reasons to breastfeed, and I would never discourage a mom from breastfeeding if she wants to breastfeed. But right now, the research doesn't conclude that breastfeeding alone or what mom eats during breastfeeding can prevent food allergies. So another area of really exciting research in an area where I think we have a lot to learn still, but we know some, is in the microbiome. So when we think about the microbiome of mom, so we're thinking about perhaps vaginal delivery and how microbiome or microbes are transferred from mom to baby, or breastfeeding, right? How mom's microbes might be transferred to the baby during breastfeeding, or mom's gut health during pregnancy and childbirth can also have an impact. All of these things are part of the transfer of microbes from mom to baby. And this transfer and or how mom's microbiome is to begin with can, it seems, have some influence on the development of atopy or certain types of diseases. What we know is that there is a difference in the microbiome for children or adults who have food allergies as compared to those who do not. There seems to be a decrease in diversity in these babies and children who go on to develop a food allergy, and that's significant. There's a difference. We know that there's a difference. The challenge is we don't really know why there are differences. We also don't always know what is an ideal microbiome, right? We don't really know yet what is an ideal microbiome. So we do know that there is a difference. We don't exactly know why or how to manipulate that, but we do know what are some of the things that influence those differences. So as we think about practical applications for this or practical things, what we know is that antibiotic use during pregnancy and early infancy can influence the microbiome. So just like in all other areas, we want to encourage responsible use of antibiotics. That doesn't mean that people don't use antibiotics. If they're necessary, they should be used, but of course they should be used judiciously. Same thing for proton pump inhibitors or other types of GERD management in infancy in particular. We know that the use of these medications can impact microbiome. So we want to make sure that we're careful and judicious about that use as well. Vaginal birth versus cesarean birth, that has an impact. There's not always a choice, but if there is, certainly a vaginal birth seems to be a healthier choice for the baby. Breastfeeding versus formula, there's some difference. There are formulas now that are starting to add probiotics and prebiotics to formulas. Those, I think, still need a lot more research. And certainly we have found that formulas, while they are the best option if moms choose not to breastfeed or unable to breastfeed, they don't exactly mimic the benefits of breastfeeding. And then exposure to farm animals and dogs. There's consistently research that shows us that being around farm animals and dogs has some positive benefit for prevention or reducing the risk of food allergies and atopy. There is some research around prebiotics and probiotic supplementation during pregnancy and during breastfeeding, and they do seem to perhaps show some benefit, but we need a lot more research. The reality is that probiotics are strain specific. The benefits are strain specific. They're dose dependent. And I think because we tend to manipulate with probiotics in single strains, we have less outcome or less benefit. There seems to be some more additional benefit for multi-probiotics, so multiple types, strains of bacteria. But I think that we still need a lot more research. There's just not nearly enough research. I would never suggest that probiotics or prebiotics at this point can prevent food allergies. We don't have the research that shows that. So I think this is an area of exploding research. There's a lot still to learn, but we don't have the answers yet. At this point, we know there's a difference. We don't know how to manipulate it positively just yet. So what are the current guidelines from the American Academy of Pediatrics? Well, what they say is, I think, what the research continues to support, and that is that evidence does not support dietary manipulation or avoidance to prevent food allergies, either during pregnancy or during breastfeeding. So here are the key takeaways for this section. The maternal diet manipulation doesn't prevent food allergies. Unfortunately, we can't tell moms to eat or not to eat certain foods in order to prevent food allergies. It just doesn't seem to be, the research doesn't support that at this point, which I think is a good thing in some ways. That the more we can liberalize the diet and encourage moms to eat all kinds of food, that's a very good thing. And I think promotes a healthier and more diverse diet, which I think is in bullet 2. This high quality, more diverse diet is beneficial for lots of different reasons, and it may have protective benefits for baby and for mom. You know, we know that long term these ways of eating are healthier. They can support a more robust microbiome, and they can prevent all kinds of other diseases. And you know, women really should ask their doctors and talk with their doctors more about the risk and benefits of medications and methods of delivery and all of those kinds of things. And I think this just goes along with, you know, promoting a more conversational approach to pregnancy and an early infant feeding as well. So here's our last poll. I'm going to ask Kelly to pull up our last poll, and this is the one that's going to focus on early infant feeding. And I'm wondering what you guys think. When should commonly allergenic foods be introduced to babies? After 12 months, before 12 months, at around 6 months, but not before 4 months, or if high risk, after 2 years of age. And this is where we've seen so much change. So I think I'll be interested to see what you guys think. If you take a minute, go ahead and make your selection and submit it. And then let's see what you guys think. So there's some of you who think after 12 months of age. That's a very common one we see. Before 12 months of age, at around 6 months, but not before 4 months. And then 1% if high risk after 2 years of age. And I think that's another one. That's all of these are recommendations we have seen. And I think we continue to see some confusion because of that. But those of you who said at around 6 months, but not before 4 months, you're right on. Let's dive into what the research tells us in this area. So when it comes to early introduction, you know, if we think backwards, there was for a long time this recommendation to avoid allergens during infancy, right? And yet we continued to see the rates of allergies increase. So even though the recommendation was in infancy not to feed allergenic foods or the highly allergenic foods that we're most familiar with, we still saw the rates of food allergies increase over the last 20 years. Well, researchers in the UK discovered this remarkable difference between genetically similar babies in the UK and in Israel. And they wanted to figure out what was going on. In Israel, they had, or in the UK, they had 10 times as high of rates of peanut allergy as they did in Israel. And in Israel, babies ate this common weaning food you see here called bamba. And many of you may have heard bamba. You may be familiar with bamba. Bamba is basically a corn puff that has peanut butter baked into it. So it's a peanut butter and corn puff, sort of like a peanut butter Cheeto. And it's ubiquitous there. Everyone eats it. The babies eat it. It's sort of a family snack. It's what moms all carry around with them. And they feed their babies this food. And so the researchers wanted to figure out, was this the determining factor? Was this the defining factor? So out of this question was born the LEAP studies, the Learning Early About Peanut Allergies study. This is the LEAP study that I'm going to talk about. In this LEAP study, what they did was they recruited 640 infants who were at high risk for peanut allergy because they either had severe eczema, moderate to severe eczema, or they had already been diagnosed with egg allergy. And then they split them into two groups randomly, and half of them ate peanut foods when they entered the study. So they started eating peanut foods between 4 and 11 months based on when they started the study, and the other half avoided peanuts. And they followed these children for 5 years. And at the end of 5 years, they did an oral food challenge with all of the children to determine how many of them went on to develop a food allergy. And what they found was up to an 86% reduction in peanut allergy at the end of this 5 years. So this was a huge intervention and incredibly successful when we think about preventing peanut allergy in these babies who had such a high risk. So they found that early introduction was both effective and it was safe. They didn't have high rates of anaphylaxis. There were no deaths. There were no major negative impacts on any of the children. So what was happening? You know, I mentioned eczema, right? And I've said that a couple of times now. And in that previous slide, you saw the high-risk infant was considered the severe to moderate eczema. And a lot of children who go on to develop a food allergy, not all of them, but perhaps 3/4 of them have some severe or moderate eczema in infancy. And what they think is happening is that, you know, our skin is actually infiltrated with immune active cells, right? So our immune system starts on the outside of our body to protect us. And what's happening is the skin is broken in these infants, and because of that, the proteins and other things that are in the environment get into the skin and activate the immune system, and they begin the process of sensitization through the skin. So even though these babies may not have been eating the food, if the food is in the household, and most of these highly allergenic foods are foods that are everywhere, right? That all families are eating them. Because of that, the dust in the house actually contains the protein, and so these babies were becoming sensitized through the skin. But when they also ate the food, the immune system was trained. It was also activated and trained that these foods are not dangerous, that these are foods and they are safe things. So there was this difference between the shift from perhaps allergy straight over to tolerance in many, in the majority of these cases. So the researchers wanted to determine, did they prevent food allergies or did they just delay it? And so the LEAP-ON study was born from the LEAP study. And what they did was they asked the children who'd been eating peanut to stop eating peanut for 12 months. And at the end of 12 months, they did another oral food challenge to determine, had they just prevented food allergy, or had they just delayed food allergy, or did they actually prevent it? And what they found was that the children who had started eating peanut food in infancy did not develop peanut allergy at any higher rate than the general population. So they had not just delayed the development of peanut allergies, they had turned it off. They'd prevented it, which was amazing. But this was all in the high-risk population. What about the rest of the population? And the majority of babies are not going to fall in that high-risk category, at least not what we know of at this point as high risk. Most babies don't have eczema. Most babies don't have already an existing allergy. So the researchers started another study called Inquiring About Tolerance, or the EAT study. And in this study, they recruited exclusively breastfed infants for the early introduction of 6 commonly allergenic foods. And in Europe, sesame is considered to be one of the most common allergies. So they included sesame in this research. And what they did was they recruited these babies, and at 4 months, they began eating one of these foods. So they randomly started with one, and then they added all of the other ones. Well, what they found was that it was difficult to adhere to. Parents had a hard time feeding their babies all of these foods in the amounts necessary in order to meet the protocol. So it was difficult to get these babies to eat enough of the foods. They had a hard time getting them all in. But they did find that there was a decrease in food allergies at the end of the study overall. So there were fewer rates of any food allergy at all in the babies who started eating these foods early. And when we look specifically at peanut and egg, for the families that followed the protocol, which was 2 grams of protein per week or more, there was a reduction in peanut and egg allergy. So the good news from the study is that even though it was difficult for them to adhere to the protocol as it was specifically designed, what they found was that this diverse diet, including these highly allergenic foods, was safe. Again, just like the LEAP study, they didn't have major rates of anaphylaxis. They didn't have any deaths. They didn't have any severe reactions necessarily. They found that there was a significant decrease. There was in this peanut and egg, and there was a decrease in all food allergies. So it's a positive outcome, even though there were some negative things about perhaps the design of the study. So again, thinking beyond these smaller studies or thinking more about population application, there's a study called the CHILD study out of Canada. That's a cohort study, a birth study, that looked at 2,669 babies through 3 years of age. So this is a general population, not necessarily high risk. These are just general babies that were recruited into this study. And they compared rates of sensitization. So every 6 months, they tested for sensitization. Now, this is definitely a weakness of the study, because it wasn't like they were doing, they weren't testing for allergy necessarily by doing oral food challenges. They were just checking skin prick tests, I think. I don't think they did serum IgE, but they might have. And they were looking at peanut, egg, and milk in particular. And what they found was that when parents started feeding these foods early in the first 12 months, so they're really looking, and when they say early, they're talking about that first year. When parents started feeding these foods in that first year, they had significantly lower rates of egg and peanut allergies down the road. Milk was not as impacted, but peanut and egg were definitely reduced. And when we looked at babies who ate peanut, egg, and milk, an egg after 18 months, I think there was a 3 times increase in the rates of allergy for peanut and egg when it wasn't introduced before 18 months. So again, what it showed was this significant reduction in the risk of developing a food allergy just by feeding these foods early in that first year. And then what about egg? There's another study that was published called the Petite Trial, and this was a study out of Japan where they looked at high risk, going back to, again, high risk, those eczema, babies with eczema. Egg allergy around the world is actually one of the most common allergies. And depending on where you are in the world, it can be as high as 10% of babies go on to develop an egg allergy. The good news for egg allergy is that many babies will outgrow their egg allergy, but it can cause anaphylaxis. And of course, we want to avoid any allergy if we can. So in this particular population, what they did was they fed them egg white powder. So this is a pasteurized heated egg white powder in very small doses, starting at 6 months, 50 milligrams a day, every day for the first 3 months. So from 6 months to 9 months, they fed them 50 milligrams rather, and then they bumped it up to 250. And they actually ended up stopping this study early because it was so successful. So I think that this was a good study to show that this early introduction, consistently feeding these foods, and that's another thing that all of these studies showed, was that early introduction plus consistently feeding these foods reduces the risk of allergy. So what do we know? So again, thinking about breastfeeding and diet diversity in infancy. So we talked about breastfeeding and diet diversity from the mom side. So what about in infancy? Well, we've already talked about breastfeeding. It doesn't prevent food allergies in infancy, but it may reduce the risk of other types of diseases. There's limited research on diet diversity in infancy. Again, going back to sort of heterogeny in research or differences in terminology, not having those standardized. We don't have as much research on diet diversity in infancy, but there is a little bit. And the studies that have been done, including a study called the Pasture study, showed that there is an inverse association between diet diversity and food allergy risk. So the more diverse the diet is in the first year, according to this study, the lower the risk of food allergy. It's not cause and effect, but it is an association, and I think that that's something to pay attention to. Again, thinking about the Mediterranean diet, we know that it can have some potential in infancy. One of the challenges, again, to using the Mediterranean diet language is that there's, even within the research, there's some differences in what they described as a Mediterranean diet. The two sort of key things we know is that this dietary pattern of Mediterranean diet in the research for infants looks at a higher level of fruits and vegetables and the inclusion of fish and seafood. So where are we going, or where are we now? Sort of helps, I think, to look back at where we came from and think about the shifts in our thinking around food allergies. We know that, in 2000, so, 20 years ago, the American Academy of Pediatrics recommended avoiding the top allergens, right? So they were very clear about avoiding the top allergens. And the belief was that by reducing the burden on an immune system, perhaps we could avoid allergy. But we didn't see a reduction in the rates of food allergies after that advice was given. And in 2008, AAP actually came out and said, the evidence doesn't support that approach. We need more research. So they didn't specifically say in 2008, feed babies allergens, but they actually said that we don't really know. They didn't say proactively feed, but they didn't say, they did say that we don't necessarily have the research to support that. And then in 2010, the NIAID came out with their guidelines on diagnosis and management, again, supporting what the AAP says, and that is that the guidelines, or that the research doesn't support avoidance to prevent food allergies. And then in 2015, after the LEAP study, we got consensus reports specifically about peanut. And then the NIAID added addendum guidelines to their management guidelines about preventing food allergy, again, very focused on peanut. And then finally, last year, the American Academy of Pediatrics released their revised reports that specifically talked about peanut and how we could prevent food allergies, and focused highly on peanut, but also started to focus on egg as well. And then we know a lot less about other foods. So let's talk about the guidelines we have right now. So the National Institute of Allergy and Infectious Disease, the NIAID, has these addendum guidelines. So I've talked to you about a lot of different research. And we had, when these guidelines came out in 2017, we really just had the peanut data to look at. But since then, we've gotten a lot of new information. So these NIAID guidelines are focused on peanut because that's what we had. So they really broke babies down into 3 groups for potential risk, right? So they called them group 1, 2, and 3. I've added the low, moderate, and high risk here because I think that makes more sense to my brain than just group 1, group 2, and group 3. But know that they don't specifically call it high risk, moderate, or low risk. They just say group 1, 2, and 3. So group 1 is really that LEAP baby, the baby who's got egg allergy or severe eczema already. These are the babies who we think are more prone to developing a peanut allergy. And the recommendation for those babies is to discuss with the pediatrician before introducing peanut foods. There may be the recommendation by the pediatrician or allergist to do skin prick testing or IgE testing, and they may recommend oral food challenge in the office or doing the first introduction in the office. The recommendation for this group is to introduce peanut food starting around 4 to 6 months, and they should eat 2 grams of peanut protein 3 times a week. So we're looking for 6 grams of peanut protein a week in this high risk group. This is going to be the smallest group, right? This is the smallest group of babies. All the other babies are going to fit into group 2 and group 3. The vast majority of babies are not this high risk group. And the recommendation for these babies is to, they don't necessarily have to see the pediatrician. There's no testing recommended, and they should start at home. They should start at or after 6 months. So those of you who said you should start feeding at around 6 months, but not before 4, you were right on. That's what the NIAID guidelines say as well. And the recommendations here are really more liberal, right? They're less specific about the amounts or how frequently, but there is always the recommendation that once peanut foods are introduced, they're kept in the diet. So what about AAP? Again, they concur with the NIAID guidelines. They also go on to say that, that there's no need to delay the introduction of other allergenic foods, including eggs, fish, and any other allergenic food as well. Now, we do have new practice parameters that were just released last month, and they build on what we have previously seen. So the guidelines that I've talked about so far are based on the research really prior to 2017 or leading up to 2017. So leading up to the NIAID guidelines. But now, and since then, we've had a lot of other research in other foods, and specifically around egg. There's very good research, as I've outlined already, about egg introduction as well. So peanut and egg are recommended in the new guidelines to be fed starting at around 6 months, but not before 4, for all infants. And in these new guidelines, which were released from the American Academy of Allergy, Asthma, and Immunology, the American College of Allergy, Asthma, and Immunology, and the Canadian Society of Allergy and Clinical Immunology, these 3 groups got together to create these new practice parameters. And the recommendations here are, again, introduce these foods to all infants. And it actually eliminates the recommendation to see a pediatrician or an allergist in advance. Now, parents can always do that. If they have questions, if they have concerns, of course, it's something that we want them to do. It's totally fine for them to talk with their pediatrician and even seek a specialist referral if they think they need it. But the guidelines here say that it's not necessary that we screen these babies in advance, even if they have eczema. The reality is, if they're those babies who have eczema, we don't want to delay introduction, because that earlier introduction is probably most beneficial for this specific group. They also go on to say, once the food is introduced, to keep it in the diet. And they talk a lot about diet diversity. So even though the research is still it's still emerging, we still don't have equivocal research as far as like we know for sure that diet diversity that looks like this is going to prevent food allergy. In these new guidelines, they do talk about diet diversity. So as a mom and a foodie and a dietitian, I love that, because I think having a diverse diet has many benefits. If it can help prevent food allergies, all the better. These guidelines also really emphasize shared decision making and the importance of talking with parents and having a decision made together. They also support the same guidelines I've talked about with regard to manipulating mom's diet or breastfeeding, and they actually talk about hydrolyzed formula, which I didn't actually talk about. Hydrolyzed formula does not prevent food allergies and is not protective against those. So one of the things we really haven't talked about is developmental readiness. And I do think that that's another important thing to keep in mind. And it is something that the new guidelines talk about. I get a lot of questions as I talk about early introduction about developmental readiness. And people say, well, how can a 4-month-old be ready? And the reality is some of them aren't ready, but sometimes they are ready. And we have to think about the fact that we're feeding for multiple reasons, right? So we're feeding for nutrition. We're feeding about, thinking about growth and developmental milestones that are more than just food. And now we're also thinking about allergy prevention. So we want to make sure the baby's ready. We don't want to feed these allergenic foods or any food before a baby is ready, but we do want to be paying attention so that when they're ready, we're ready to move forward as well. The other thing is to remember that these early foods aren't necessarily they're not meant to replace formula or breast milk. These are complementary foods, right? They're meant to complement breastfeeding and formula. Those are still going to be the primary source of nutrition for babies. But when we're ready, how do we start? So the first thing to remember is to start with a healthy baby. We want to start with a baby that doesn't have any illness, doesn't have a fever, no vomiting, because then we might misunderstand what's happening and think that the reaction is as the result of a food, when really it's going to be about a virus, something like that. The other thing is starting early in the day, making sure that we start early in the day. We have that 2-hour window to observe a baby. And then we want to start with a full-size portion, or we want to start with a tiny amount, even though we may prepare a full-size portion. We'll start and then wait 10 minutes and then move forward. And I have some recommendations in a minute that I'm going to tell you. Actually, I think I took that slide out. So in the NIAID guidelines that I've already mentioned, there are some very good, very clear and concise guidelines for introducing peanut foods. And I think those are good guidelines you could use for any food if you think it might be a problem for a baby. So for instance, if you have a baby that you think may have an egg allergy, but the doctor has given the go ahead to introduce at home, then these guidelines might help with egg introduction, for instance. All right, so when we're thinking about introducing peanut, of course, we want to make sure that we're not introducing whole peanuts, that we're not introducing peanut butter that hasn't been diluted. Those are choking hazards, so we don't want to give those to an infant, but we can thin it with a little warm water, breast milk, or formula, or even put it into a puree. We don't want peanut to be the very first food a baby gets. We want to make sure they're eating some other foods, but once they've started eating a couple of different kinds of foods, then it's probably safe to go ahead and start peanut and other allergens as well. So the peanut puffs that I mentioned Bomba. There are several other brands that make a puff product. Those can also be melted and fed to baby with a spoon as well. Here are some very easy ways. There's a website that the National Peanut Board has developed called preventpeanutallergies.org that has lots of great resources, including videos, handouts, and links to all of the major guidelines that I've mentioned so far. What about other foods? We've talked a lot about egg, and I would say that egg, I would say is, the evidence is moderate. We know that egg, there's some potential for egg early, so we want to make sure that we're getting that in. There's less evidence about other foods, but we are starting to see growing evidence for some of the other foods. What about reactions? Well, I think that these are some of the symptoms. They're similar to the symptoms that we've seen in the previous slides about reactions. What we know about infancy is that severe reactions are very uncommon in infancy, but as a child gets older, it's more likely that they may have a severe reaction if they have a true allergy. So we really want to try to do introductions better done earlier, because the reaction, if they are allergic, is probably going to be milder. So I think that's something to keep in mind. And when it comes to infants, the most common reactions are hives and vomiting. Doesn't mean some of these other reactions can't happen, but those are the things to be most conscious about in infancy. So here's some practical takeaways. I think, one of the things that I always like to emphasize when it comes to early feeding, especially when it comes to the allergens, is helping parents be confident feeders. We certainly want to evaluate the risk. We want to make sure our parents know exactly what to do and what the baby's risk might be. But the biggest part that we can play, I think, as health professionals, as dietitians, is really to give them the confidence to feed their babies and to have fun. Feeding babies should be fun. And I think that even when it comes to allergens, we want to make that fun. So now let's look a little bit at the dietary guidelines for Americans. And I'm going to sort of breeze through some of these last few slides. I don't want to shortchange this because I think it's important, but I also want to make sure I have time for your questions because I see that we have a lot coming in. Now, the dietary guidelines for Americans have not yet been released, but they should be released this year. So we're in December. I'm anticipating them any day. What we do have right now is the scientific report, which was issued in June of 2020. And this scientific report is separate from the dietary guidelines. It is advice to the Dietary Guidelines Committee in what things should be included. And as many of you know, for the first time, we're going to have included in the dietary guidelines advice for babies, infants through 2 years of age. The dietary guidelines previously only addressed nutrition recommendations for ages 2 and up. So this is new for us, and I think that it will be really, really exciting to see. The recommendations on early introduction or prevention of food allergies really focus on infant feeding because that's where the evidence is, right? And in the guidelines or in the scientific report right now, the recommendation is strongly for peanut, and it talks about the strong evidence for prevention of peanut by eating peanut foods or introducing peanut foods in the first year of life after 4 months. So again, thinking about that 6 months is probably the sweet spot for introduction. But some babies are going to start eating earlier. And if they do, then peanut foods can be introduced earlier as well. And especially if they're in that higher risk group, there may be some benefit to starting earlier. There is limited evidence about other types of disease. So we know that peanut early can help prevent food allergies, peanut allergies, but it may not impact eczema or asthma. So unlike some of the other research that we've seen around reducing wheeze and reducing asthma, peanut specifically introduced early may not have any effect on that as well. And then egg. So I mentioned peanut and now egg. So the new dietary guidelines are probably going to include this recommendation around egg and the fact that moderate evidence shows that introducing egg in the first year of life can reduce the risk of egg allergy. This is, I think, really exciting as well. So introducing egg early helps to reduce the risk of egg allergy. But when it comes to other foods like fish and beyond fish, wheat, soy, some of the other top 8 as in particular, all of them basically say that there's limited evidence. And that's the way it is. We just don't have the research yet on these specific foods to show whether or not they're specifically preventive. What we do know is that it's safe to introduce these foods. And again, thinking about diet diversity, a diverse diet may have some very good benefit for baby and infancy, for preventing food allergies, but even for preventing other types of diseases down the road. So this is our summary slide. You know, I think going back to my recommendations about feeding babies, making it fun and exciting, I think that it's really important for us to think about feeding babies in a much broader way than we might have in the past. You know, how can we diversify a baby's diet early? That should be part of our focus when it comes to early infant feeding so that we're supporting a diverse palate, a healthier baby, and so that we can help prevent food allergies. So food allergy prevention is just one part. We want to make sure that we're introducing peanut and egg early, somewhere around 6 months, maybe earlier in some infants, but not before 4 months. And we want to keep it in line with the guidelines and the expert advice. Also, we know that unfortunately at this point, there's not a perfect maternal diet for preventing food allergies. We do know, however, that diversity and a healthy diet is important all the way through pregnancy and in breastfeeding, even if they don't necessarily prevent food allergies. So I think my friend Jada is going to help us with your questions, and I suspect there are a lot of them.
There are quite a few. Thanks so much, Sherry, for that amazing presentation. The key takeaways are definitely of importance when it comes to early introduction. Consistency and introduction play a major role. Now, like Sherry said, we will transition into the Q&A portion of the webinar. And also, we have some questions already, but if you have any questions for Sherry, I'll give you a couple minutes to submit them below using the chat feature at the bottom of your screen. To kick it off, our first question is from Susan. What forms of peanuts would you recommend at 6 months? Peanuts and peanut butter may not be appropriate at that young age.
Yeah, so in the slides that I mentioned, peanut butter and powdered peanut butter are both completely appropriate, and so is the peanut puffs, depending on the baby. You know, some babies at 6 months aren't going to be ready for finger foods like that, but some might be. So I think that it really depends on the baby. You can melt those puffs, so both with peanut butter, powdered peanut butter, or peanut flour. You may have heard it called peanut flour, or with the puffs in early feeding. So if it's some of their first foods, melting those by adding some warm water, breast milk, or formula is going to make it super safe and make it really easy. Great question.
Yeah, great question. Another question that kind of builds off of this: at what age do you not need to dilute the peanut butter?
I think that really depends on the baby. I mean, when we think about, it depends on how the baby's eating, right? So if the baby's doing some self-feeding, you can spread a very thin layer of peanut butter, not a thick layer of peanut butter, but a very thin layer of peanut butter on like a piece of toast or some sort of very small, safe finger food that they're eating. You could certainly do that. I think full strength peanut butter, if you will, you never want to give a baby a spoonful of peanut butter. I think until, older toddlerhood or even 4 years old, probably.
Mm-hmm. Oh, this is a good one. Can a child grow out of an allergy or intolerance?
Yes, they definitely can. That's a great question and one I get all the time. Absolutely. Children can outgrow their allergies. When it comes to peanut, it's less common. So somewhere around 20%, it's not nothing, 1 in 5. So somewhere around 20% of children with a peanut allergy might outgrow that peanut allergy. When it comes to milk and eggs, the numbers are higher. So somewhere around 80% of the milk of children may outgrow their milk allergy. Somewhere around 60 to 70% may outgrow an egg allergy. We are seeing children hold on to those allergies a little bit more than we have in the past. And I think that, researchers are trying to figure out why that's the case.
Perfect. Another question that we have from Amanda. In regards to the mom's diet and breastfeeding, is there any research to correlate with what the mom doesn't eat relate to the prevalence of food allergy development?
There's not. There is no research that supports withholding foods from mom's diet. So limiting those foods in mom's diet does not seem to prevent food allergies either. And I think that's probably something we've seen far more often than women purposely including certain allergens in their diet, right? Women are more likely, I think people in general are more likely to take things out of the diet than they are to add things. And I think what the research is showing us is we really should be adding things instead of taking things out.
Mm-hmm. Absolutely. Another question: why should peanut not be the first food if in the right consistency? And the person says, you mentioned it should be introduced early, but not as the first food. Why is that? Peanut is a great source of iron as well.
Well, I think, the main reason is because first of all, you want to make sure the baby's ready. I think we don't want to introduce a food like peanut or another allergen in the very beginning in case the baby's having some other issues. Maybe the baby has severe reflux. Maybe the baby isn't ready and they have some gagging or they have some severe spitting out that you could confuse with allergy, right? So by introducing these other foods, you kind of can get a feel for whether the baby's ready to be eating and they're more developmentally ready to be eating these foods. It also shows, some babies may have some other issues, right? So they might have FPIEs or they might have some other kind of issue that's not necessarily IgE mediated food allergy, but might be another type of intolerance or atopy. And I think you want to give a chance for that to show up, and it sort of prevents people from automatically assuming that whatever's happening is a food allergy.
Mm-hmm. Great. So we've had a couple of questions regarding allergic reactions. So if a baby shows an allergic reaction, how soon can that food be reintroduced?
Well, I mean, I think if you're pretty sure the baby's having a food allergy reaction, then you want to see the allergist and have them help you determine when that is. I don't think that's something that as a practitioner, as a dietitian, I wouldn't be giving a parent advice about when to introduce something that they know their baby's reacting to. I think they need to talk to the allergist first. I mentioned that anaphylaxis is uncommon, but that doesn't mean it never happens. So I think we want to avoid a severe reaction if we can. And by working with the allergist, we can help make sure that happens.
Awesome. Another question, I used to get this a lot when I was a clinical dietitian as well. Emily Gim, she says, oftentimes I have moms that are cutting out dairy and gluten due to food allergies or eczema in the baby. And my understanding of the research doesn't show enough evidence to change the diet.
Yep, you're right.
Perfect.
not evidence. Now it depends on the reaction and it depends on the baby. And, I wouldn't say that there's never a reason to do that, but I would definitely say it wouldn't be my first recommendation because the evidence doesn't really support it. And the second thing is if a mom takes a food out of the diet, it should be temporary and they have to reintroduce it as well. So if they take it out, there has to be that reintroduction to prove that in fact the change was because of the elimination.
Mm-hmm. Another question, do adults who have allergies have more risk of having babies with allergies?
So that's a great question. And the new guidelines that just came out actually talk a little bit about that risk. And the answer is yes, there is some increased risk, but what that risk isn't completely understood. And the risk is not a significant risk. In what I mean is that it's not like a 20% risk or a 50% risk. It's probably less than 10%. So it is some increased risk, but we don't understand exactly what it is. And I would say that in those cases, again, early introduction, goes back to being the way that we can help prevent even in that case.
Mm-hmm. Another question, can a child present with only oral allergy symptoms and nowhere else?
So oral allergy syndromes like excessive drooling or pawing at the mouth, something like that can happen. And sometimes that does happen. I would say that, in the event that happens multiple times with a specific food, that would be the kind of thing to talk to the pediatrician about to sort of get some advice on helping to figure out, because you don't want to continue to introduce something that may cause a reaction and may cause a severe reaction eventually. But I would say that it's less common that would be the specific kind of symptom.
Mm-hmm. How are we on time?
Let's see, maybe take one more question before we wrap up.
Okay, let's make it a good one. Okay.
They're all good.
I know, they're all so good. Let's see. There were some questions specifically. You kind of answered that one. Okay, this is the good one. Okay, hold on one second. Okay, this is a good one. Does the length of breastfeeding impact the prevention or increased risk of allergy?
Yeah, so that is a great question. And as I think I showed in one of the slides, there are two different studies. One shows that longer duration is preventive. One shows that longer duration increases the risk. So I think the answer is we don't know for sure. I think, one of those populations was general population. One was the population with eczema. And then the other thing is if mom's breastfeeding longer and that delays early introduction of allergens, then the risk may be higher for a child to develop a food allergy. So breastfeeding is great. It provides tons of, benefits for mom and baby. I was a long time, breastfeeding mom. So I'm a proponent of breastfeeding, but it's not the only healthy way to feed babies, and complementary feeding needs to be part of that as well.
Absolutely. Well, that wraps up our Q&A. Thank you, Sherry.
Thank you. And I would say that if people have additional questions and your question didn't get answered, or you want to reach out to me, my contact information is on the screen.
Thank you both. And thank you so much to the National Peanut Board for sponsoring this session. Just as a reminder, y'all will get an email by early next week with the CPEU certificate for dietitians, and you'll also get an email with the recording of the presentation and the slides so that you can revisit anything you're interested. So thank you all, and we'll see you next time at our next webinar.
Thank you. Have a great day.
Thanks. Bye.